Hello, students. Let's begin our lecture. The first part of our lecture is paraneoplastic syndromes. Paraneoplastic syndromes, this is a heterogeneous group of disorders, cause symptoms independent of tumor invasion or metastasis, infection, ischemia, metabolic or nutritional deficits, or tumor treatment. Can occur before, during, or after the cancer diagnosis. This is mechanism of paraneoplastic agent, cancer cells, cause cytokines, hormones, and antigens, and these remote cells and cause specific symptoms. Associated cancers. It can be small cell cancer of the lung. The most common cancer associated with paraneoplastic syndromes, probably because of its neuroectodermal origin. Other neoplasm commonly associated carcinomas of the breast, ovary, other adenocarcinomas, adenocarcinomas, lymphoproliferative diseases, especially Hodgkin disease and thymoma. Endocrine paraneoplastic syndromes. Hormones can be produced from eutopic or ectopic sources. Eutopic, this expression of a hormone from its normal tissue of origin, whereas ectopic, hormone production from an atypical tissue source. Ectopic expression leads to high level of hormones, abnormal regulation of hormone production, and peptide processing. This is endocrine paraneoplastic syndromes. It can be hypercalcemia of malignancy, syndrome of inappropriate antidiuretic hormone secretion, Cushing syndrome, non-islet cell hypoglycemia, male feminization, diarrhea or intestinal hypermotility. All these common syndromes. This is rare. Oncogenic osteomalacia, acromegaly, hyperthyroidism, and hypertension. Humoral hypercalcemia of malignancy occurs in up to 20% of patients with cancer. Non-malignancy, recent onset of hypercalcemia, very high level of calcium, maybe initial presenting feature of malignancy. Hypercalciuria, hypophosphatemia, suppressed PHT levels, metabolic alkalosis, increased PTHRP, in 80% of cases. PTH, parathyroid hormone, increased 125 OH2 in lymphoma. Cushing's syndrome caused by ectopic ACTH production accounts for 10-20% of Cushing's syndrome. SCLC in most common case. Less marked fat gain and centripetal fat redistribution. Fluid retention, hypertension, metabolic alkalosis, glucose intolerance, and psychosis. Increased pigmentation, marked skin fragility, and easy bruising, severe hyperkalemia. High plasma ACTH level, more than 100 picogram per milliliter, and do not respond to glucocorticoid suppression. Paraneoplastic hematologic syndromes. It can be renal cancers. It can be erythrocytosis, granulocytosis, thrombocytosis, eosinophilia, thrombophlebitis unknown protein, autoimmune anemia, cancers associated with syndrome you can see in this table. Treatment. If erythrocytosis, the resection of the cancer usually resolves the erythrocytosis. Radiation therapy or chemotherapy, phlebotomy may control any symptoms related to erythrocytosis. Paraneoplastic granulocytosis does not require treatment. The granulocytosis results when the underlying cancer is treated. Eosinophilia. In most patients who develop shortness of breath related to eosinophilia, symptoms resolved with the use of oral or inhaled glucocorticoids. Paraneoplastic thrombocytosis does not require treatment. Thrombophlebitis. Trousseau syndrome. The coexistence of peripheral venous thrombosis with visceral carcinoma, particularly pancreatic cancer. This is treatment of this unfractionated heparin or low molecular weight heparins, warfarin. Touch tenor is 2 to 3. Continue warfarin for 3-6 months or local molecular weight heparin for 6 months. Contraindicating to heparin, placement of filter if patient have contraindications of heparin, placement of filter in the inferior vena cava, Greenfield filter, to prevent pulmonary embolism. Prophylaxis. Patient with cancer who undergo a major surgical procedure, heparin prophylaxis or pneumatic boots. Breast cancer patient undergoing chemotherapy and patients with unplated catheters should be considered for prophylaxis. 1 milligram per day warfarin. Paraneoplastic neurologic syndromes. In 60% of patients, the neurologic symptoms precede the cancer diagnosis and can occur during or after cancer diagnosis. Clinically disabling paraneoplastic neurologic syndromes occurs in 0.5 to 1% of all cancer patients, 2-3% of patients with neuroblastoma or small cell lung cancer, and 30-50% of tumor. Most neurologic syndromes are mediated by immune responses triggered by neuronal proteins, onconeuronal antigens expressed by tumors. Many antibody-associated immune responses have been identified. This antibody react with patient's tumor, and their detection in serum or cerebrospinal fluid especially predicts their presence of cancer. What syndromes of the brain? Brainstem and cerebrum, focal encephalitis, cortical encephalitis, limbic encephalitis, brainstem encephalitis, cerebral dysfunction, autonomic dysfunction, paraneoplastic cerebral degeneration, apsiclonic myoclonus, syndromes of spinal cord, syndromes of dorsal root ganglia, and multiple levels of involvement. Syndromes of peripheral nerve, chronic and subacute sensomotor peripheral neuropathy, vasculitis of nerve muscles, neuropathy associated with malignant monoclonal gammopathies, peripheral nerve hyperexcitability, and autonomic neuropathy. Syndromes of the neuromuscular junction, syndromes of the muscles, polymyositis, dermatomyositis, and acute necrotizing myopathy. Syndromes affecting the visual system. This is cancer-associated retinopathy, melanoma-associated retinopathy, and uveitis. Dermatologic syndromes. A wide range of skin disorders. The underlying mechanism is usually speculative. Growth factors, cytokines, hormones can occur before, during, or after the cancer diagnosis. Так. No, this is a different type of disease, dermatological disease, acanthosis nigricans, acquired hypertrichosis, necrolytic migratory erythema, geratum repens, Sweet syndrome, pruritus, paraneoplastic pemphigus, and acquired ichthyosis. Vascular diseases. Leukocytoclastic vasculitis, polyarthritis nodosa, Raynaud syndrome, erythromelalgia. Evaluation and diagnosis of paraneoplastic syndrome. Characterize abnormality, obtain laboratory studies and biopsy is necessary. Carefully elicit any additional symptoms and signs. Eliminate common causes. If there is no obvious etiology, consider a paraneoplastic syndrome. If findings are consistent with a known syndrome, screen for underlying malignancy. If signs and symptoms are consistent with a known paraneoplastic syndrome, undertake a search for an unknown primary cancer or a recurrence or progression of a known primary tumor. Screening should include a careful physical examination, including breast, gynecologic, and prostate evaluation, basic hematology, chemistry, and urine studies, chest radiograph, and mammogram. CT scan of the abdomen and pelvis is indicated if there are any suspicious symptoms, signs, or laboratory abnormalities. And the next part of the our lecture is clinical utility of rheumatologic tests, a guide to interpretation. We can see in what time rheumatology lab test can appear or was appears. Rheumatologic lab tests are relatively young, have varied sensitivity and specificity, little value as screening test. Blind ordering can lead to diagnostic confusion. Acute phase proteins that show an increase more than 25% with inflammation, synthesized in the liver. Group 1 increased by 50%, C3 and ceruloplasmin. Group 2 increased T4-fold fibrinogen, haptoglobin, alpha-1 antitrypsin, alpha-1 chymotrypsin, alpha-1 glycoprotein. And group 3 increased by several hundred-fold CRP, serum amyloid A. What is erythrocyte sedimentation rate? Indirect measure of acute phase protein, fibrinogen, measured by the Westergren method. Vertical column 200-300 millimeter long, and this is the distance the red blood cells travel in 1 hour. This is a normal ASR. It can be 0 to 20, but it can increase with age, and it's in women. What factors can increase ASR? Inflammatory disease, infections, malignancy, increase in globulin proteins, end-stage renal disease, intensive tissue necrosis, pregnancy, and age. Factor that increase ASR. This decrease ASR. Elevated plasma viscosity, increased red blood cells polycythemia, abnormal red blood cells shape, sickle cell, hepatic necrosis, hypofibrinogenemia, congestive heart failure, extreme leukocytosis, trichinosis. Etiology for SAR more than 100. Infection, malignancy, and rheumatologic disease. How to use SAR? Not very sensitive or specific. Use as diagnostic criteria only for temporal arteritis and polymyalgia rheumatica. Useful in monitoring polymyalgia rheumatica, Takayasu arteritis, rheumatoid arteritis. Can be useful for monitoring disease, cause, and treatment response. Extreme elevations in the ESR rarely occur without evidence of serious disease. What does CRP stand for? C. Polysaccharide from the pneumococcus cell walls. Acute phase protein group 3 exclusively produced by hepatocytes, direct measure of inflammation. Normal levels of C-reactive protein less than 1, moderate elevation 110. It see in most of the rheumatic condition, rheumatoid arthritis, systemic lupus erythematosus, Sjogren's. Marked elevation more than 10, see in serious bacterial infections, severe rheumatoid arthritis, vasculitis, polymyalgia rheumatica. Levels rise within hours of stimulus. Peaks within 2-3 days. Half-life 8 hours. With effective treatment of the underlying cause, levels can normalize with 24-48 hours. This is C-reactive protein versus ESR. C-reactive protein rise quickly, falls quickly, direct marked with inflammation, narrow range of results, high sensitivity, high specificity, high reproducibility, not affected but by factors age, gender, anemia, red blood cell shape, plasma proteins. ESR rise slowly, falls slowly, indirect marker or inflammation, wide range of results, moderate sensitivity, moderate specificity, and reproducibility, affected by many factors. Antinuclear antibodies. What exactly are they? Antibodies that bind to various antigens in the nucleus of a cells. How is it measured? In direct immunofluorescence. Antinuclear antibodies, the method of indirect immunofluorescence is say, take patient serum and add it cells. If there are antibodies, they will bind. Add a fluorochrome tag, view under a fluorescent microscope. If it's light up, in then positive 1 to 40. Dilute sample and repeat. This is antinuclear antibodies. Staining patterns, observer dependent, non-sensitive, non-specific, only loosely associated with certain disease status. What does the staining pattern mean? If homogeneous, this is systemic lupus erythematosus. If RIM, lupus. Checkered, Sjogren, and mixed connective tissue disease. Diffuse, non-specific. Nuclear scleroderma, anticentromere, CREST syndrome. Antinuclear antibody associated diseases. If No, rheumatic. What associated? Значит, it can be rheumatic condition, lupus, drug-induced lupus, scleroderma, Sjogren's, mixed connective tissue disease, polymyositis, dermatomyositis, rheumatoid arthritis, vasculitis. It can be autoimmune disease, Graves, primary biliary cirrhosis, Hashimoto thyroiditis, autoimmune hepatitis, and miscellaneous agent, primary pulmonary hypertension. Antinuclear antibody with age. For every year after 50, percentage of antinuclear antibody positivity increased 1% per year. For example, age 50, 1%, 55%, 60, 10%. Rheumatic causes of positive ANA. No, drug-induced lupus and lupus, scleroderma, Sjogren's, mixed connective tissue disease, myositis, and rheumatoid arthritis. Clinical indications. NA is not a good screening test given its low specificity. Presence of NA does not mandate the presence of rheumatologic illness. A negative NA is more useful and marked lupus very unlikely. NA titers correlate poorly with disease, actively show serial measurement and not recommended. A positive NA with anti-centromere pattern is very specific for limited scleroderma. Further testing of NA. This can be done to determine the exact nuclear target antigen. Some of these antibodies are specific for a particular disease. Include double-strand DNA, Smith, Arrow, and SSA, LA-SSB, U1RNP, scleroderma 70, and centromere. Anti-double-strand DNA, specificity for systemic lupus erythematosus 97%. Presence in about 60% of patients with systemic lupus erythematosus. Titers correlate with disease activity in systemic lupus erythematosus. Elevation correlates with lupus nephritis, seen in drug-induced lupus. Anti-Smith, very specific for SLE, more than 95%. See in only 30% of patients. No evidence that it is useful to follow for disease activity in systemic lupus erythematosus. Important diagnostic marker for systemic lupus erythematosus. See in 97% of patients with Sjogren's. See in 40% of SLE associated with photosensitive skin rash, lymphopenia, and interstitial lung disease. In pregnant patients associated with neonatal lupus and congenital heart block. NTLA or SSB, usually see along with NTRO SSA. Can see isolated activity in primary biliary cirrhosis and autoimmune hepatitis. Anti-1 RNP. a defined feature for mixed connective tissue disease. Very sensitive for mixed connective tissue disease, but not specific. So use to rule out disease. Also found in 30–40% of patients with systemic lupus erythematosus. Anti-gastone antibodies seen in drug-induced lupus. Sensitivity of 100%. Not very specific, but see in 60–80% lupus. Drug commonly implicated: hydralazine, INH, procainamide, penicillamine, quinidine. Antisclerodermic 70. As known as anti-topoisomerase 1. Very specific for diffuse scleroderma. Specificity is greater than 95%. Sensitivity is low, range 22–40%. High levels associated with greater disease activity. Presence correlates with high risk of intestinal lung disease. Anti-centromere antibodies, usually associated with scleroderma, especially CREST. Also see in systemic lupus erythematosus Raynaud's phenomenon. Sensitivity for scleroderma ranges from 30–60%. Specificity for scleroderma is high, greater than 95. Rheumatoid factor, what is this? Autoantibody directed against the Fc portion of immunoglobulin G, can be immunoglobulin M or immunoglobulin A. Rheumatoid factor positive disease states. Rheumatic conditions: rheumatoid arthritis, systemic lupus erythematosus, mixed connective tissue disease, Sjogren's syndrome, systemic sclerosis, and cryoglobulinemia. Infection: tuberculosis, leprosy, syphilis, viral infection, parasitic disease. Pulmonary disease: silicosis, sarcoidosis, idiopathic pulmonary fibrosis, asbestosis. Miscellaneous: aging, leukemia, colon cancer, cirrhosis, hepatitis C, primary biliary cirrhosis, and sarcoidosis. Rheumatoid factor positivity and aging. Frequency of a positive rheumatoid factor increases with age. In age 2060, this is 2–4%, 60–75%, more than 70, 10–25%. Rheumatoid arthritis can be rheumatoid factor positive in 60%. Initially negative becomes positive during course of disease, 20%, and rheumatoid factor negative, 20%. For rheumatoid arthritis, sensitivity 80%, Note that up to 40% of patients with rheumatoid arthritis may be seronegative early on. Specificity for rheumatoid arthritis 80 to 95%. Higher the titer or value of rheumatoid factor, higher the specificity for rheumatoid arthritis. This is clinical indications for rheumatoid factor. Liter value as a screening test for rheumatoid arthritis. A positive rheumatoid factor does not equate with rheumatoid arthritis. In whose patient with rheumatoid arthritis, a positive factor usually predicts more aggressive erosive disease. Higher rheumatoid factor titers, higher specificity, higher positive predictive value for rheumatoid arthritis. Serial measurements are not indicated and do not correspond with disease activity. Anti-CCP antibodies to cyclic citrullinated peptide. Antibodies that target citrullinated proteins. Citrulline, a modified arginine amino acid, may be one of the major autoantigens given the local immune response. Sensitivity 50-70%, specificity greater than 90-95%, found is low frequency in other rheumatic diseases. May be detected in patients with early rheumatoid arthritis. May predate the clinical development of rheumatoid arthritis by several years. Predictor for more erosive arthritis. Indication: a disease-specified autoantibody that is very useful for the diagnosis of rheumatoid arthritis, just as sensitive and even more specific than rheumatoid factor. May predict eventual development of rheumatoid arthritis when found in indifferentiated arthritis, and a marker of erosive disease. ANCA. What are they? Antineutrophilic cytoplasmic antibodies. How are they measured? Two-step procedure. Step 1, indirect immunofluorescence assay. Take patient serum and added cells. If there are antibodies with the antibodies, they will bind. Add a fluorochrome tag. View under a fluorescent microscope. If it lights up in the cytoplasm, then it is cytoplasmic ANCA positive. If it lights up around the nucleus, when it is perinuclear, ANCA positive, sensitive but not specific. This is cytoplasmic antinuclear cytoplasmic antibodies, and this is perinuclear nuclear cytoplasmic antibodies. Step 2, enzyme immunoassay helps determine the specific antigen that the antibody to binding to two most common are proteinase 3 and meloperoxidase, not observed dependent, high specificity, high positive predictive value. Cytoplasmic ANC, more specific for vasculitis. CNC associated with proteinase 3, sensitivity reaches 90% in active generalized vaginismus. Thus, absence of NCA does not rule out vaginismus. PNC disease states: microscopic polyangiitis, Chalk-Strauss syndrome, Goodpasture's, drug-induced vasculitis, ulcerative colitis, Crohn's colitis, primary sclerosing cholangitis, endocarditis, and malaria. Less specific for vasculitis. It is associated with myeloperoxidase, helpful in differentiation polyarteritis nodosa with microscopic polyangiitis. Clinical indications for ANC testing: do not use as an screen test using the aperture and MPO increases the positive predictive value. Controversy regarding following NCAs to monitor disease activity. HLA-B27, human leukocyte antigen B27, 75 sensitivity for ankylosing spondylitis, 80% sensitivity for reactive arthritis. Low specificity. Background prevalence in 6 to 10% in Caucasian population. Rheumatologic testing. These labs are not useful as screening test. A positive test may or may not be associated with the disease. Selective ordering in patients with an protest probability or ordering rheumatoid pain is not recommended. Blood tests are useful in confirming clinically suspected diagnosis and monitoring the disease activity. The tests should be useful as adjunct to comprehensive history and physical examination. And the last part of our lecture is approach to the patients with connective tissue disease. Connective tissue diseases are a group of closely related multi-system conditions and share common signs and symptoms. Frequently makes the diagnosis of a specific rheumatic disease difficult. Connective tissue diseases can present with similar clinical features, particularly during the first 12 months of symptoms. What diseases are the connective tissue diseases? This is rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, polymyositis, dermatomyositis, mixed connective tissue disease, Sjogren's syndrome. What is non-specific features for all diseases? Fatigue, arthralgia, myalgia, depression, malaise, weight loss, fever, and lymphadenopathy. Suggestive features. Raynaud's phenomenon, dryness of mucosal surfaces, inflammatory arthritis, skin rashes, photosensitivity, mucosal ulceration, discoid lupus, and skin tightness, puffiness of digit. What is suggestive features? This is also for suggestive features. Muscle weakness, recurrent unexplained fetal loss, more than 3, usually mid-trimester. Pleurisy in the absence of infection. Vascular events, myocardial infarction, stroke at an early age. Presence of one or more of these, particularly in combination with non-specific features, increase the likelihood of a connective tissue disease. Additional investigation and/or specialist referral is then appropriate. Raynaud's phenomenon is due to variable spasm of the digital arteries. When spasm is severe, the blood flow absent and digits appear white. When spasm is partial and blood flow present but impaired, tissue over-extraction of capillary oxygen renders the draining blood cyanotic, so the digits appear blue. During recovery from spasm, reactive hyperemia makes the digit appears red, thus explaining the classic triphasic color changes originally described. Raynaud phenomenon affects approximately 5% of the general population, and it is important to differentiate primary from secondary causes. Primary usually begins during the teens and early 20s and represents an exaggregated physiological response to cold stimuli. It is usually not associated with any other disease entity. The development of Raynaud phenomenon at an older age, more than 30 years old, and especially in males, suggests the possibility it is secondary to some underlying connective tissue disease, and this should prompt investigation for an underlying cause. Raynaud phenomenon occurs in 90% of patients with systemic sclerosis, in up to 50% of cases with systemic lupus erythematosus and idiopathic inflammatory myositis. Connective tissue disease associated Raynaud phenomenon is often severe. Now we can see severe carcinosis, digital ischemia, and digital gangrene. Nephiled capillary microscopy. Dryness of mucosal surfaces. Dryness of the eyes and mouth are common subjective symptoms in the general population. The menopause, diabetes mellitus, and drugs such as antidepressants are all associated with such symptoms. Having excluded these, several additional features suggest Sjogren's syndrome, which may occur alone or in association with other connective tissue disease. Persistence of daily ocular or oral dryness more than 3 months. recurrent sensation of sand and gravel in the eyes, Zika symptoms and mucosal ulcers. Using a tear substitute more than 3 times a day. Frequently drinking liquids to aid food swallowing. Recurrent or persistent salivary gland swelling or infection in adult. Abnormal Schirmer test, elevated SR or positive antibodies, iron antinuclear antibodies, anti-Rho, anti-LA. Inflammatory arthritis. Joint inflammation is associated with joint pain and stiffness more than an hour, as well as objective evidence of soft tissue joint swelling. This needs to be distinguished from arthralgia, which often occurs in common conditions mimicking connective tissue disease. And in addition to rheumatoid arthritis, this may also be a presenting feature of the connective tissue disease. Skin rashes. The classical skin rashes associated with connective tissue diseases include photosensitivity, abnormal sensitivity to sunshine, resulting in diffuse rhematose eruption with or without blistering. This rash frequently involved the bridge of the nose and malar area and classically spares nasolabial folds. Recurrent mucosal ulceration. Clinically, this ulcer resembles idiopathic aphthous mouth ulcers and may involve the nasal mucosa. Discoid lupus, a discrete rash associated with hyperkeratosis. It frequently results in cutaneous scarring and pigmentary changes. It is often discoid lupus. It is often photosensitive, and when it involves the scalp, patchy hair loss is usually permanent. We see livedo reticularis amyloid phenomenon. Alopecia, diffuse or patchy. Skin rashes, skin tightening. In the systemic sclerosis or systemic scleroderma, there is initial puffiness and edema of the skin, particularly affecting the fingers, dorsum of hands and forearm. There are loss of definition of the skin creases of the fingers. The skin is difficult to pinch as it feels thickened and tightly bound to the deeper layers. Systemic lupus erythematosus, this is hands, and intra-articular dermatitis. Muscle symptoms. Inflammatory muscle disease such as polymyositis or dermatomyositis, is clinically characterized by subjective and objective proximal muscle weakness, which may be accompanied with tenderness and wasting. These clinical findings warrant further investigation, and an elevated creatinine kinase strongly support the diagnosis. Physical findings can be limited or may involve many organs. The potential physical manifestations is a non-connective tissue disease are best described by organ system. Telangiectasia, purpura, digital ulcerative scars, sclerodactyly, acroscleroderma, calcinosis, malarage, scoidrage, erythema nodosum, periungual erythema, alopecia, heliotropic eyelids. We can see this arch. This is heliotropic rash in dermatomyositis. Conjunctivitis, scleral episcleral disease, uveitis, iritis, or keratoconjunctiva sicca, salivary glands, xerostomia or salivary gland enlargement, reticuloendothelial system, lymphadenopathy or splenomegaly. In lungs, Rales, reason, pleural effusion or pleural rub. Heart, enlarged heart, murmur, pericardial rub, dependent edema, arrhythmia or abnormal pituitary sound. Vascular acrocyanosis, absent pulses, arterial and venous thrombosis. Gastrointestinal hepatomegaly, gastrointestinal disease, esophageal dysmotility or malabsorption syndrome, muscle tenderness, muscle atrophy or proximal muscle weakness. In joints, joint tenderness, swelling, erosion, synovitis or deformity. Nervous system, cranial nerve palsy, peripheral motor neuropathy, sensory neuropathy, entrapment neuropathy, psychosis, or personality change. What investigations we can use? Laboratory tests must always be interpreted in the light of clinical context. Approximately 5% of general population have a clinically irrelevant positive ENA in the serum, especially females, so a positive ANA in isolation may have no diagnostic significance. In contrast, someone with photosensitivity, inflammatory arthritis, and recent pleurisy may have 50% pretest probability of systemic lupus erythematosus. Clinical notes review. The value of this cannot be understood, since this may uncover a relevant fact which were not previously thought of as important. History of deep vein thrombosis, recurrent miscarriages, mouth ulcers. Common early laboratory features of connective tissue disease: cytopenia, high ASR, reversed albumin globulin ratio, urine sedimentation and SAN proteins, positive ANA, hyperglobulinemia. Investigation: a full blood count and differential white cell count. This may demonstrate leukopenia, lymphopenia, thrombocytopenia, or evidence for hemolysis. Urine dipstick and renal function. This should always be performed when a connective tissue disease is suspected. Creatine kinase, while this is often normal in cases of polymyositis, dermatomyositis, an elevated result in the context of muscle symptoms and signs clearly required further investigation. The ISRs frequently raised in the connective tissue diseases, while in contrast, the C-reactive protein may be normal, particularly in systemic lupus erythematosus. Serology. The best screening test is the anti-nuclear antibody. It is positive in up to 90% of patients with connective tissue disease. Other antibody may also suggest a particular type of the connective tissue disease or pattern of organ involvement. Rheumatoid factor, anti-nuclear antibody, and VDRL. Other studies to consider, if clinically indicated, would be C3, C4, GO1 antibody, anti-CCA antibody, anti-SSB antibody, Smith antibody, RNP, anti-topoisomerase antibody, sclerosis 70 antibody, and anti-cardiolipin antibody. Imaging studies. Findings of chest X-ray in patients with cardiopulmonary signs and symptoms can be normal or can show evidence of mediastinal lymphadenopathy, intestinal lung disease, pleural effusion, pulmonary infiltrate, pericardial effusion, or cardiac chamber enlargement. Computed tomography scan, especially high-resolution scan, can define anatomical intrapulmonary abnormality more clearly. Other tests. Pulmonary functional tests, including total lung volumes and carbon monoxide diffusion capacity, will assist in identifying patients with intestinal lung disease or reactive airway disease. Echocardiogram can best clarify chamber size and functions, estimate physiologic pressures, and identify and quantitate the size of a pericardial effusion. The Schirmer test, placing a small strip of filter paper inside the lower eyelids of an anesthetized eyes. The eyes are closed for 5 minutes. The paper is then removed and the amount of moisture is measured. A negative more than 10 mm of moisture of the filter paper in 5-minute test results is normal. Persons with Sjogren's syndrome moisten less than 5 mm in 5 minutes. This test also can have an abnormal results in patients taking medications that have anticholinergic side effect. This is eye and filter paper in shimmer test. Rose Bengal stain of the cornea can detect keratitis associated with Sjogren's syndrome. Neighbored capillary microscopy can demonstrate dilated tortuous capillary loops and areas of vascularity in patients with secondary node syndrome associated with an underlying connective tissue disease, particularly systemic sclerosis, polymyositis, and mixed connective tissue disease. On this table, we can see preceding signs and symptoms and preceding laboratory data in different connective tissue disease association. So you can see this. Thank you for attention. That's all.
Водитель скажет, что забирайте их на свои цели, то выбирайте. Когда эти инструкции. Ну, можно только отменить, а перекинуть вряд ли.
Можете запланировать эту же самую лекцию мне